You can find charts online that make sleep positions look like personality types. The soldier, the starfish, the log, the yearner, the fetal position, the freefall. But your body does not care what the pose is called. It mainly cares about four things: whether you are on your back, side, stomach, or partly upright, how your head and neck are supported, where pressure builds, and what gravity is doing to your airway and stomach. So instead of treating every named pose like a completely different species, here is what the major adult sleeping positions actually do. Start with sleeping flat on your back, also called the supine position. The soldier position, with your arms down, and the starfish, with your arms spread out, are basically variations of the same body orientation. For some people, back sleeping feels balanced because body weight is distributed across a broad surface instead of being concentrated on one shoulder or hip. But comfort depends heavily on the mattress, pillow height, body shape, and any existing pain. There is no universal rule that back sleeping automatically gives everyone perfect spinal alignment. The more important effect happens in the airway. When you lie on your back, gravity can make the tongue and other soft tissues around the upper airway more likely to shift backward. In many adults with obstructive sleep apnea, breathing interruptions are worse in the supine position than on the side. This is especially true in what sleep specialists call positional obstructive sleep apnea. That does not mean every person who snores should simply force themselves off their back and consider the problem solved. Some people continue to have significant apnea in every position. Loud snoring, choking, gasping, witnessed breathing pauses, or major daytime sleepiness deserve proper evaluation rather than a pillow experiment alone. Back sleeping also matters in late pregnancy. Research on going to sleep position has linked falling asleep on the back after about 28 weeks with higher risk of adverse pregnancy outcomes, which is why major guidance commonly recommends settling to sleep on either side in the third trimester. Waking up on your back is different from deliberately choosing it. The usual advice is simply to turn onto your side and go back to sleep. Now move to the left side. Side sleeping changes the airway geometry because the soft tissues are no longer being pulled straight backward in the same way. For many people with positional snoring or positional sleep apnea, a lateral position can reduce breathing events compared with sleeping flat on the back. But the left side has another effect that has nothing to do with the airway: reflux. The stomach sits asymmetrically in the abdomen, and lying on the left side can place the stomach and the junction with the esophagus in a geometry that makes acid less likely to remain near the opening into the esophagus. Studies using overnight acid monitoring have found shorter acid exposure and faster acid clearance on the left side than in the right side or supine positions. That is why someone with nighttime heartburn may notice a strangely specific pattern. One side feels fine, they roll over, and suddenly the burning starts. It is not imaginary. Gravity is interacting with anatomy. Left side sleeping is not a cure for gastroesophageal reflux disease, and persistent reflux still deserves appropriate care. But among sleep position effects, this is one of the better supported differences between left and right. The right side looks almost identical from the outside, but internally it is not a mirror image. For breathing, right side and left side sleep often share the main advantage of getting the body out of the supine position. In some people with positional sleep apnea, either lateral side can reduce obstruction compared with the back. For reflux, however, the right side often performs worse than the left. Overnight monitoring studies have found more acid exposure or slower acid clearance in the right lateral position. So if someone says, "I can sleep on my right side until I eat late, and then I regret everything," there is a plausible physiological reason. There are plenty of internet claims saying right side sleeping is dangerous for the heart because the heart sits slightly left of center. That conclusion does not follow from the anatomy. For most adults, choosing the right side is not known to damage the heart. The meaningful side-to-side difference with the clearest everyday evidence is reflux, not some dramatic heart compression story. Then there is the fetal position, side sleeping with the hips and knees bent, sometimes only slightly, sometimes curled tightly enough to look like you are trying to disappear into your own blanket. Physiologically, the fetal position belongs to the side sleeping family. The major airway and reflux effects come mostly from which side you are on, not from the fact that your knees are bent. The degree of curling can matter for comfort. A gentle bend may feel natural because it reduces the sense of tension through the trunk for some sleepers. A very tight curl can also place the hips, knees, shoulders, and neck in sustained flexion. Whether that feels better or worse depends on the person, the mattress, the pillow, and any joint or spinal problems they already have. What the evidence does not support is the idea that the fetal position reveals a hidden personality, emotional trauma, or a particular psychological need. It is a posture, not a diagnosis. Sometimes a curled-up sleeper is simply cold. Next are the log and the yearner. These names sound like they should have different medical consequences, but they are mostly arm and leg variations of ordinary side sleeping. In the log position, the body is relatively straight. In the yearner, the arms reach forward. The important mechanics are still lateral pressure on one shoulder and hip, the alignment of the neck, and whether the upper arm is supported or hanging forward. If you wake with a numb arm, aching shoulder, or stiff neck, the problem may not be that you chose the wrong named category. It may be that one body part has spent hours compressed, unsupported, or held at an awkward angle. Pillow height can matter a lot here because a side sleeper usually needs enough support to fill the space between the mattress and the side of the head. Too little support lets the head drop toward the bed. Too much pushes it the other way. Research linking specific name poses like log or yearner to unique health outcomes is weak. So those labels are useful descriptions, not separate biological modes. Now for stomach sleeping, or the prone position. The freefall pose is basically a stomach sleeping variation with the arms up around the pillow. Stomach sleeping does something interesting to breathing. Because it keeps you away from the flat on your back position, it may reduce obstructive events in some people with sleep apnea. Small clinical studies have found improvements in apnea measurements with prone positioning in selected patients. But that evidence is nowhere near strong enough to say stomach sleeping is a standard treatment for sleep apnea. It is better thought of as a position that can change airway behavior in some bodies. The trade-off is the neck. Unless you are using a special setup that lets you breathe straight downward, sleeping on the stomach usually requires turning the head to one side for long periods. Pillow thickness can also push the neck into extension. That can be uncomfortable, especially if you already have neck problems. Strong evidence that stomach sleeping automatically causes chronic neck pain is limited, but the mechanical reason some people wake up stiff is not mysterious. Stomach sleeping also concentrates pressure differently across the front of the body and can be uncomfortable during pregnancy as the abdomen grows. Early in pregnancy, lying on the stomach is generally limited more by comfort than by a special danger from the position itself. Later, it often becomes impractical. There is also a position people rarely include on the classic charts, the three-quarter position. You are not fully on your side and not fully on your stomach. One knee is usually bent forward, the torso is slightly rotated, and half the pillow has somehow vanished underneath you. This hybrid position can reduce time spent completely supine, so it may share some of the breathing advantages of side or prone sleep, but it also introduces rotation through the trunk and neck. Whether that feels excellent or terrible is highly individual. There is not a large body of research proving that the three-quarter position has a special health effect of its own. Its importance is mostly mechanical. It changes pressure points and moves the airway away from the pure back sleeping orientation. Finally, there is elevated or semi-reclined sleep. This is not a classic pose like the fetal position, but medically it can matter more than several of the famous names combined. Raising the upper body changes gravity in two useful ways. First, it can make it harder for stomach contents to travel upward into the esophagus. Studies of head-of-bed elevation and wedge sleeping have found reductions in nighttime acid exposure or reflux symptoms in some patients. Second, elevation can make the upper airway less collapsible in certain people. Clinical studies have found improvements in sleep apnea measurements when the upper body is raised, although the effect varies and should not be treated as a replacement for prescribed therapy. The detail that matters is elevating the torso, not just stacking the head on a mountain of pillows. If only the neck bends forward while the chest stays flat, you have changed neck position more than body orientation. And that brings us to the position most people actually use, several of them. Sleep is not a photograph. Healthy adults commonly shift position during the night. You may fall asleep on your left side, spend part of the night on your back, turn to the right, curl up near morning, and have no memory of any of it. So the best position is not a universal winner. It depends on what problem you are trying to solve. If your main issue is positional snoring or obstructive sleep apnea, getting off your back may help, but significant symptoms still need proper assessment. If nighttime reflux is the problem, the left side and upper body elevation have some of the strongest positional evidence. If pain is the issue, support, pressure distribution, Mattress characteristics, pillow height, and your individual condition may matter more than a catchy sleep position label. And in late pregnancy, side sleeping carries specific safety guidance that does not apply to the general population. One final distinction matters. All of this is about adult sleep. Infants' safe sleep recommendations are different. Babies are generally placed on their backs to sleep because the risk-benefit calculation is completely different from adult snoring, reflux, or neck comfort. The strange thing about sleeping positions is that a tiny change in orientation can alter several systems at once. Rotate 90 degrees and gravity starts acting differently on your airway. Turn to the other side and reflux can change. Raise the torso and both breathing and stomach acid may behave differently. Your body does not know whether you are a soldier, a starfish, a yearner, or a freefall sleeper. It only knows pressure, anatomy, support, and gravity. And those four things explain far more about sleep position than any personality chart ever will.